I'm going to assume that we're all here for the same reason, which is to delve into the mysteries and complexities of the impact of the Affordable Care Act on our state and those who live within it. There's a lot of verbiage and confusion and fear out there. So hopefully after this evening's presentation, we'll leave here with more understanding of what this approach to health care will mean to our fellow Illinoisans and to us. First, we're going to hear from Dr. Stephen Potzik, and then we're going to hear from Julie Hamus, and after they both speak, we'll definitely have time for questions, so keep your questions in the forefront of your mind, and hopefully we'll be done at least by 9 o'clock. So let me introduce, if I may, our first speaker. Dr. Stephen Potzik has a long, distinguished career of healthcare. He's a licensed physician with a master's degree in maternal and child health and epidemiology, and is board certified in preventive and occupational environmental medicine. Stephen was the principal U.S. Public Health Service official in Region 5, which encompasses Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin, where he was in charge of federal public health programs, including emergency planning, responses, and bioterrorism. So, welcome, Stephen. We're most interested in your insights into what's commonly known as Obamacare, and we're all ears, so.
Thank you. Ed, is this mic open? Yeah. You can hear me okay? Yes. Good. Well, certainly it's a pleasure to be here tonight. I've actually been a county health officer, a state health officer, a city health officer, and a federal health officer. And I've been appointed under a Republican president, a Democratic president, a Republican governor, a Democratic governor, a county board, a Democrat chairman, and a Republican. So I've actually had a wide variety of political processes, but I've never been a political appointee. I've always been appointed based upon professional qualifications. And since this has had a lot of emotionalism attached to it, what I'm going to try to do is not give you any of my personal opinions. Only give you what the Act says or what published, peer-reviewed articles say about it. Nothing from the Republican Party, nothing from the Democratic Party. I will try to give you only what I consider reasonable facts based upon my experience of looking at professional literature. Okay, I get a lot of questions, and I'm going to try to do some of these questions fairly quickly. There was a lot of controversy about death panels, and believe it or not, even in the last month, someone has said, well, there's still death panels in the Act. Well, there's not death panels, because what death panels was talking about is that physicians could be reimbursed for voluntary counseling for end-of-life decisions, the so-called living wills, to actually reimburse them for it. It was determined that it was called death panels because it was so controversial. The original Act, the original section of the Act, that section was no longer included. So some people thought it was a great provision, but because of the political controversy, it was taken out. So, no death panels. Okay. People say, how long? Why is the Act so long? Well, it's so long because it tries to cover at least 3 major components: cost, value, and the moral imperative. And in the United States, as a democracy, those are very, very complex issues and all very interrelated. And the other thing is, in any kind of law, and this, by the way, is the law. I get my exercise every day just holding it up.
Really small type?
It's not real small type. But in any legislation, and I've had the privilege to write legislation at states and federal levels, as well as county levels, what you have to do is many times you have to link things that are in there and correct things because there are changes that are made. So a lot of the sections in there refer to other laws and then change those based upon the new provisions. So there's not only trying to address these complex issues, it's trying to make sure that no attorney can come and sue based upon conflicting provisions in different laws. Okay, so the three issues, and believe it or not, even though we have a lot of controversy here, believe it or not, all Americans that I have ever talked to believe at least one, if not more of those things, need to be changed in the United States. Number one, costs. Costs are not transparent in the medical community, and costs clearly have to be better managed. We have to get better value. And thirdly, it's a moral imperative. And I will briefly go over those three. And the reason I want to go over those three is that I still get questions. In fact, 2 questions in the last 6 weeks. I don't still understand why we have the act, why we have the law. Aren't we doing well in the United States? You know, I have insurance, so what's the issue? So I'm going to just briefly touch on that. Okay. Number one is that cost. Medical bills are the number one cause of bankruptcy in the United States. We can't see all of it. I think that says 30% of care is not actually helping patients. And what does that mean? That means that tests and procedures are being done that don't need to be done. And secondly, when you get a screening procedure, for example, and there's a lot of market dynamics out there saying you should be screened, you know, we got low-cost screening, it leads to a snowball effect. And that snowball effect actually leads to more care, and sometimes unnecessary care. So, who said this? Who said that 30% is not actually helping patients and sometimes helps them, and it's a snowball? Who actually said this? Who said that was the American College of Physicians. Physicians. The American College of Physicians is the professional organization of internists. The internists in the United States said that 30% of our health care is unnecessary and potentially harmful. Okay. Ed, are you able to collapse it at all? Okay, all right. Well, one of the issues with cost is that people that don't have insurance tend to get the bigger bills because they get charged what the hospital or the physician actually charges. As you know, for those of you that have insurance or Medicare, you know that Medicare and private insurances negotiate rates and will only pay up to a certain amount, not the full charge. So if you don't have insurance, you're likely to have more of a bill, not less. Okay. It's a long slide, so I'll try to make it short. You don't know in advance what it's going to cost you, right? Okay, so this patient went to the emergency room not too long ago, not in this area, and there was a question about whether they needed a CT scan of the neck. And the doctor said, it's questionable, I would prefer it be done, but it's questionable. So the young guy, who was a young person in his 20s, said, well, how much is it going to cost me? He's trying to decide, what's the cost benefit? And the hospital said, well, anywhere between $2,000 and $10,000. And we won't know until we bill. Whoa, well, we won't know until we bill. That means you have to have the test and the billing. So the point is, costs are not transparent. You can't usually make decisions in America based on health care, based on what it's going to cost you. So what did the guy say? Well, $2,000, I'd probably do it, but I can't do it. It would break me. I couldn't do it for $10,000. So he didn't have it done. By the way, he turned out to be okay. Okay, so there is no other industry in the United States that the price for the same exact thing varies so widely. No other industry. Okay, so what does it cost people? Well, for family coverage, it costs about, in 2012, about $16,000, and out of pocket, it was about $4,300. So you can just see that even with insurance, health insurance, the premiums are quite costly, and the total amount per family is expensive. Okay, so what happened? Well, overall inflation, this is 10 years, and you can see that overall inflation, earnings, insurance premiums, and the workers' contributions. So what's happening is that not only is it becoming more costly, the costs are being shifted to the employee and the people themselves. Okay. So again, costs. What's the consequences? You know, if there's no consequences, who cares? But there's consequences. Even the insured people, this is in 1 year, have used up all or most of their savings. 10% of those even insured, and 20% of those that are uninsured. So even if you have insurance per year, you're stuck with some substantial healthcare costs. Okay, and again, it stops getting people care. This just shows that people that are uninsured, even people insured, many times do not have access to care. Okay, this is the median out-of-pocket costs for Medicare. As you can see, that just keeps going up and up. That's out-of-pocket costs. Out-of-pocket costs, percent of income, 16% of those on Medicare, 16% of their income goes for health care. This happens to just be a chart that shows, some people say, well, you know, all big employees give health care. Well, a lot don't. As you can see, there's only 61% that actually offer health care in the marketplace. Okay, so that was cost. How about value? Well, to talk about value, we have to know how much it costs per person. This is actually a fairly, this is 09, and it's actually about $8,500 now. So about $8,500 per person in the United States versus, you can see all these other industrial countries. You can see, we are way out there, way out there. And where are we with value? Well, this is the World Health Organization's of the world's health systems, 37th. 37th. So value, very high cost, very low value. Okay, so what does the health organization say? And I won't talk about how they define the systems, but I will say that what they say is health systems are subject to powerful forces and influence that often override rational health policy making. You think that might be the United States? No, not at all. Okay, so life expectancy. Okay, life expectancy, there's two components here, and actually there's a slide that actually I didn't put on that's actually a little bit newer, but it's the same basic data. Health life expectancy. So as you can see, health life expectancy in the United States on the industrial is 24th. But look at the other things. Actually, females and males have similar kind of ratios, but everybody is lower. Everybody is lower. This doesn't show up very well. I had eye surgery in the last couple of weeks, couple of months, so I'm not sure I can see anything. But what this is supposed to show is there are scientific ways of calculating how you can reduce mortality based upon health care. And these are the studies that show this. And it basically shows that the United States is very low on reducing mortality based on health care. And what you can't see, and it was important in some way, that the decrease was substantially in all these countries except the United States. The decrease was very small in that time period, very small. And the conclusion was that it's difficult to disregard the observation that the slow decline in U.S. Mortality coincided with the increase in uninsured. So that means that we can't do as well with decreased mortality based on health care because we have so many people that can't get the health care. So again, value as far as a country is concerned. This just shows that the United States, again, this is women are so much more, have problems than the rest of the world. So how many are uninsured? Well, this is 2010, and as you can see, it's approaching 50 million people uninsured, non-elderly, because we assume the elderly are basically Medicare, right? So non-elderly. Okay, so who are these people? These are the non-elderly, and as you can see, one or more, actually, 61% actually are full-time workers. 61%. Part-time, 16, and no workers, 24%. But the point is, 61% of these people work full-time in the United States and are uninsured. Now, so what? So what if people are uninsured? You know, what does that do? You know, I just go to the emergency room for care. Well, what it means is 20,000 people die each year because they don't have insurance, and these are just different conditions. Now, this line shows that if you have private insurance versus uninsured, this is the risk ratio. So what that means is that about 3 times you're likely to die of late-stage breast cancer if you're uninsured in the United States. 3 times. So if you're a woman uninsured and you have breast cancer, you're going to be diagnosed in late stage. And what does that mean? Obviously, much more pain and suffering, much more problems with the family, right? Because you have now a loved one who's quite ill, and you have a ton of additional health care costs. So that's a very significant risk ratio, 3 times. Okay, Affordable Care Act. There are 10 titles or chapters. There's 955 pages. People do say, well, I go to the website and there's 2,000 pages, so what do you mean it's 955 pages? You know, you're cheating us. Actually, when you do go to the website, since they want you to see it better, they actually have multiple screens for the same for the same page in the act. So there really is only 955 pages, but if you go online, you'll find about 2,000. Okay. People have said, well, how was it originally established? What model did they use? Well, believe it or not, one of the significant models was Massachusetts. And what they found is those provisions were an individual mandate, a tax penalty, subsidies, private insurance exchanges, and extended Medicaid. Wow, does that sound familiar? That's exactly the beginning of the Act, the Affordable Care Act. Those are the models that were used, and what has it showed? Well, it shows that private insurance actually grew, and that there was a dramatic reduction in non-group insurance prices. And these are uninsured versus the United States. I'm sorry, you can't see that very well. So the United States uninsured went up, Massachusetts significantly went down. So the model was there, and that all those provisions, many of those provisions actually were used in the Affordable Care Act. Okay, people say, okay, but it's going to cost the country a ton of money. Well, you have to look at different resources. And one of the resources I tend to look at is the Congressional Budget Office. The Congressional Budget Office is nonpartisan. They're professionals, and believe it, when I was at the federal level, when I did federal legislation, believe it, these guys don't monkey around. They don't listen to anybody. They only go to published research to look to see how they can do the analysis. So they're not politically swayed. And what it showed was that there will be, these are cost savings, that these will be substantial cost savings over time. And they did some analysis based upon some time things. But basically, there was a rumor out there that, oh, the costs are going to be so much different and not the savings. Well, as you can see, these are lines for different time periods, and they're the same. So that's the Congressional Budget Office. Okay. Now, however, the Supreme Court did knock out a provision, right? They said that states cannot require the expansion. And so what would happen based upon the Supreme Court? And this is, again, the Congressional Budget Office, but it also brings in a political component. The Joint Committee on Taxation is actually a joint political staff committee. So both of them agreed that the net cost reduction would be $84 billion, and that would be about 3 million more people will be uninsured. So what it did is it said more people will be uninsured, but there will be actually a cost reduction, a few billion dollars, $84 billion cost reduction. So that's what the Supreme Court, when they decided to do that, that's actually what the analysis was. Okay, so people say, okay, why do you use the Congressional Budget Office? Well, because there's not a lot of other, objective bodies out there that do this kind of research. But people said, but they're biased. They're biased, right? Okay, so some pretty astute people, actually from the University of Chicago, right here, decided to analyze previous estimates of the Congressional Budget Office to see how well they did. And there were 3 major federal legislation that they looked at that had costs associated with it. And this is what they found. That the CBO overestimated costs in one of them. The cost savings actually were greater in another one, and costs were 40% less in another one. So in each case, the Congressional Budget Office underestimates savings and or revenue and overestimates costs. Just the opposite of what people were complaining about. Just the opposite. Now, there are some theories, but I told you I'm not going to give my theory. But one of the theories that is published about why this happens is because these guys do report to the Senate and to the Congress and the House, and they don't want to be wrong the opposite way, right? If they're going to be wrong, they're going to be conservative in costs and liberal in costs and conservative in savings, right? So the Congressional Budget Office always underestimated savings and overestimated costs. As you know, this was trying to be repealed numerous times. I think the House tried to repeal it about 37 times or something like that. Well, this is from the head of the Congressional Budget Office, and this is to the Speaker of the House, and this is April 24. And basically what he said, if you repeal it, you will have a net increase in the federal budget deficit of $109 billion. So if you repeal the act, the federal deficit is going to increase by over $100 billion. That's the official analysis by the Congressional Budget Office. Okay, some controversial issues. One of them is contraceptive methods. So people say there are these federal bureaucrats that are deciding what people are going to get and not get. Well, actually what the Act says, there's two groups that will make the recommendations of who gets what, okay? The first group is the Institute of Medicine, and the Institute of Medicine has been around. Abraham Lincoln actually established the American Academies of Science, and the Institute of Medicine is one of those. And basically, a bunch of professionals, non-federal people, all professionals, all volunteers, very well known in the community, in the professional community, made this recommendation. A whole bunch of stuff. Obviously, annual well women visits, gestational diabetes, breastfeeding support, HTI counseling, HIV screening, all kinds of stuff. And one of them was contraceptive methods. So this was a recommendation by the Institute of Medicine. Now, I didn't give names or anything here, I just gave titles, but these are all very well-respected professionals. Obstetricians, pediatricians, internists, and as you can see, the Institute of Medicine was established in 1970. This is not a fly-by-night organization. Okay, so what was some of the data they used? Well, this is one of the studies that was used and why they made that recommendation. This shows on this line the percent of married women who use contraception. And so it goes from 0 to 100%. This is the number of abortions per married women per year by country. This happens to be the country of Georgia, not the state of Georgia. As you can see, as contraception use increases, the amount of abortions substantially decrease. Some of them are as much as 3 abortions per woman per year. Married women. Married women. So that's one of the reasons they made such a recommendation, because the science shows that the more people in a country that uses contraception, the less abortions that actually occur. Okay, the second group that makes recommendations is the U.S. Preventive Health Service Task Force. Many of you might know about it because they publish recommendations for screening every year. Some of them are somewhat controversial sometimes, but they always base on science. And it's composed of a whole bunch of experts in the field. And you can't read this, I did put names and titles. There are 16 voluntary members. They all volunteer their time. Almost all of them are practicing clinicians. And they're from very well-known teaching institutions. Okay, so what are the provisions? There's a lot of provisions, but they all try to address whether it be pre-existing conditions, rebates on care of cost because it was too high. You can't impose lifetime dollar limits. If some of the insurance companies in the past, if you have a serious illness with a lot of healthcare costs, they'll go back. They went back and they looked at your application, and if your application had a technical problem with it, maybe the date wasn't quite right, or your address didn't have the right zip code, they disallow. They cancel the insurance. Well, you can't do that anymore under the Affordable Care Act. So you can't no longer deny insurance because of pre-existing conditions, and you can't remove it because you've got some technical errors. Okay, I get a lot of questions about small business. This is a topic on its own. I'm just going to hold a couple of things. First of all, these are wonderful websites that you can look at for specifically. The first myth is that employees are required to have health insurance for their employees. That's not true. No employer is required to have health insurance for their employee. However, if you have more than 50% full-time equivalents, there are potential penalties or taxes that you'll have to pay, but only if one or more of those employees get subsidized care through the marketplace. So if none of them get it, you don't get anything. But what it does is it say to employers that we want people in the United States to be insured. And if they're going to get federal subsidies for their insurance, then you've got to try to help pay your fair share. But that's only if you have 50 or more full-time equivalent employees. There's other provisions. There's tax credits. Some of you that might be small businesses, you've already in 2010 hopefully have applied for tax credits, which will go up to about 50% of your costs in 2014. Also, I need to point out there are safe harbors and there's transitional relief. So if something, you can't quite figure out how you fit in certain things, there's a safe harbor and there's transitional relief. But if you want more information, these are really great websites to look at. Oh, and by the way, people said you have handouts. I don't have handouts, but it will be on the League of Women Voters website, and it will be on TV. So you can go to the website, and you can actually look at the particular slide that you're most interested in and get the information. Okay, and there's still other provisions that started in 2010. Some of my neighbors love the one about extending coverage age 26 because many of their young adults in their household did not have insurance. And it creates a whole bunch of other things, including some matching funds. This is kind of an interesting one. It increased payments to rural healthcare providers to help them continue to serve their communities. That's a real issue in the United States, rural communities. So it helped to do that. This is a cartoon about a 26-year-old saying that he can get health insurance. And he says, well, that's great, I'm 26, but do I have to come back to my old room? No, you don't. In fact, some people don't even know this. You can even be married. You can have a married child under 26 who can still get insurance through you. So it's really quite broad. It also cuts out the donut hole, which I won't spend a lot of time on, which has been very costly for seniors on Part D. 211 features. Let's see, if I want to highlight, what do I want to highlight? I want to highlight probably one item on there, and that is one of the issues with private insurance, as you know, we're a capitalistic society, gets obviously profits, right? It so happens that a lot of those profits do go for lobbying, and that's why the insurance industry is very powerful, but also it goes to shareholders and people that invest in the company and should get some return, right? So it's not a bad thing. The problem is when it becomes excessive, it adds to the health burden of the United States, okay? And so what this says is that we're going to say that 85% of all premium dollars, these are large employer plans, have to be spent on healthcare services. And if you don't, you get rebates. And I don't know, some of you might have got $250 checks in the mail. There were rebates. A lot of you didn't because those rebates went directly to the insurance company or the employer. Okay. There will be a number of procedures that will try to limit costs. And I'll try to go over a couple concepts. One is called bundling. You probably have seen a number of articles that say Mayo, is starting to do networks like with Condell and North Shore, and you know that Northwestern now, has bought Lake Forest Hospital, and so there's consolidation. And one of the reasons that consolidation is happening is that in the future, the Act is trying to move the system from a volume system to a value system. So instead of reimbursing healthcare providers by the volume of tests they do and the number of hospital days, they're trying to shift it to the value, the outcome for the patients. And one of the ways they do it is that and they can elect to do that. Providers don't have to do this, but they can elect to be part of a network that bundles the fees. So they will get, for a particular condition, a certain amount of money, and that amount of money will have to care for their inpatient and outpatient services. Right? And if that healthcare system saves money, they will get 50% of the savings back to the healthcare system. And the feds will save the other 50%. So it's kind of a win-win situation. Number one is better care, managed care, and secondly, it's cost saving. So there's a number of these provisions, which I really don't have time to go into, but the point is that there are very specific methods to try to control costs and increase quality. Before I get into this, I might have taken one of the slides out, but I did want to mention on costs. So how much does the United States pay on healthcare costs per year? Who knows? $1 billion? $100 billion? $1 trillion? $2 trillion? $2.8 trillion? $2.8 trillion on healthcare costs. $2.8 trillion. How much does the United States spend on food every year? Food. A lot of restaurants, our own food. Total amount paid for in the United States per year on food. 4 trillion? 6 trillion? 1.2 trillion. 1/2 of the healthcare costs. 1/2 on food. Just gives you some perspective of what is happening in our society as far as healthcare costs. Okay, there's different exchanges, which I understand my colleague from the state is going to talk a little bit about. So I'm just going to continue to go into some of the other things. Let's go into penalties. People think that everybody's going to be affected as far as having to deal with penalties and insurances in the United States. Well, this is a pyramid of, again, non-elderly. There's 275 million projected in 2016 of non-elderly. 219 will be insured by employers, Medicaid, Medicare disability coverage, individual insurance, and will not be affected by the Act. Okay? So a very 219 million, so a very large percent will not be affected at all. Not be affected at all. I'll say it one more time. Will not be affected at all. 24 million will qualify for exemptions and will not need to do it. And 32 million will be somewhat affected by it. So again, the vast majority in the United States will not be affected by the mandate, the individual mandate. Okay, so who will be affected? I get this question a lot, so I will try to be brief. But the point is, if any of these things apply, your religion is opposed to it, you're undocumented, you're incarcerated, you belong to a member of tribe, you have certain household income, and you're going to be paying more than 8%, you don't have to do any of that. So there's no penalty. If that's true, and you're on Medicare, Medicaid, TRICARE, veterans, such and such and such, yes, you don't have any requirement. So there's a penalty. So what is the penalty? So if there's a smaller number, potential penalty, and that penalty for 2014 is $95 per adult, $47 per child, or up to $285 or 1% of the income. As you can see, the penalty becomes greater. But when it comes to the cost of health insurance, the penalty is small, very small. Because remember, the cost of health insurance for a family was something like $16,000. So when you consider the penalty, it's fairly small. And basically what that penalty does, it says to people, if you're not quite sure what you want to do, you can take the penalty and decide later, you know? I mean, if you have to get insurance, but don't want to do it, you know, you can maybe take the penalty. Now, some people might say, but the penalty gives me no value. So maybe rather than spending the money on the penalty, I'll buy the insurance. And for many people, there's subsidies depending on your family income. Remember, the Supreme Court said this is a tax. It is a tax. I won't go into these, but these are where the funding sources are supposed to come into. And I'll just point out one, and that's the savings from the Medicare Advantage program. Who has Medicare Advantage in this room? Anybody? No? Wait, Medicare, but Medicare Advantage is really where it's sort of all lumped in. You get your drugs, you get your outpatient, you get some primary prevention kind of stuff. They're phasing that out. And the reason they're phasing it out, because it's a fairly small percent of Medicare recipients actually get the Advantage policy. And they also, it costs about $1,000 more per person, federal costs per person, with the studies show no real benefit. So there didn't seem to be a reason to try to continue to subsidize that program. So it's planning to be phased out. Tax changes. There are a number of tax changes. A tax, as I mentioned, without qualifying coverage. There's taxes on different activities. And in fact, people that are higher income people will start paying more for the Medicare wage tax, which is now 7.5%. So if you're working, there's a 7.5% tax that you pay in order to get Medicare in your future life, you know, future years. That will go up for high earners. And I believe it's a family of $250,000. It'll go up, I think, to 10%, or an individual up to $200,000, I believe. Again, these all can be found, but the point is there are taxes. Excise tax on certain mechanical devices, pharmaceuticals. That's one of the reasons that the pharmaceutical industry was concerned, because, again, the pharmaceutical company is having annual fees imposed. I've started to already have them. So there are fees, there are taxes. Okay. I get a lot of questions because this came up a lot in the literature and in the media. What's happening with the Ryan proposal? Now, this is not me. This is the Congressional Budget Office. Okay, Congressional Budget Office. And this was a letter to Paul Ryan in April of 2011. And what it said was that with your proposal, this will be the beneficiary share, and this will be the beneficiary share with current Medicare. And the reason for that is Ryan's proposal stated that there will be a set sum of money that will be given, and then you go to the private marketplace to get your insurance. Well, when that set sum of money means that if you compare it to current Medicare, you would have to pay more money out of your pocket. Again, this is Congressional Budget Office. This is not me. That says that the Ryan proposal will substantially increase the cost to the elderly. One of the things I found was extremely interesting. I always thought that the senior citizens and that were the most people interested in Medicare. Well, this was a study that was done that shows that even 18 to 49-year-olds, very high percents of every population group in the United States thinks that Medicare is very important. Remarkable, because normally you think, well, the people that are like, in their 20s, they don't care very much, right? They show that they have very, very strong support. Oh, questions, previous questions. I don't know if I'm going to take previous questions now, because we're going to have questions today. But I do want to highlight just one at the end. 5 more minutes. Oh, good. I don't think I probably need 5 minutes. The law does not create a new government-run insurance program. People say, oh, it's a new government-run insurance program. It's not. It's private insurance. What's government-run is the components that try to make costs more transparent, to give more choice, to give better value, and to obviously decrease the number of uninsured in the United States. Because, again, I don't have to stress enough, if you are uninsured, you have much higher healthcare costs, you have much later diagnosis, you have much more pain and suffering, and you have an extended amount of costs that could have been avoided. Okay? So there is some very, very strong reasons, value reasons, cost reasons, and moral reasons why you want to cut down on the number of unemployed in any country. I got some references. These are all objective references. Of course, some are government references, but again, because the government references talk about the law, so they give you a lot of good information about the law. So, with that, I will stop. Thank you.
Thank you. Am I on? Yes. Okay. I know you've got questions, but remember, after Julie speaks, we're going to have a time for questions from everybody. But let me introduce our next speaker, Julie Hamas. Ms. Hamas comes to us with a background and a mission that would hopefully, or would both, I think, at least to me, impress and exhaust us. Her resume would keep us here all night, so just let me point out a few things about Julie. She's an attorney by trade, a former state representative for 11 years, was named a top, are we okay? Yep. Was named a top legislator by over 50 organizations, is a fellow of the Harvard Kennedy School of Government. She was named by Crane Chicago as one of the 25 women to watch in 2007, and by the Tribune's business section in 2013 as one of their recognized people to watch. In 2010, she was appointed director of the Illinois Department of Health Care and Family Services, a huge state agency responsible for providing health care coverage for adults and children who qualify for Medicaid, and for providing child support services to help ensure that Illinois children receive financial support from their parents. She has a $17.7 billion budget, a staff of 2,400, with 59 offices throughout the state. There are 47,000 doctors in Illinois and more than 1 million poor or disabled Illinois Medicaid recipients. The Tribune calls her responsibilities Herculean. And Julie is here to tell us about all that, and we're here to listen. So, Ms. Hamas, you're on.
Thank you. Can you hear me? Is it on? I guess it's on. Wow. Good evening, everybody. It's so nice to be here. I do enjoy the League of Women Voters. I have been to many, many things throughout my career, and I always have found that League members and League participants like you and the public are always really try to be well-informed and nonpartisan and thoughtful about what the issues of the day are. And I just want to do a quick shout out to Kathy Rigg. Raise your hand, Kathy. Kathy was a state representative at the same time that I was, and she represented a portion of Lake County. And if you know Senator Susan Garrett from up here, she was the other state rep. Karen May and Kathy Rigg were the two state reps. And I always enjoyed working with her. So, you know, Steve did quite a job of taking 995 pages and giving you a lot of detail. I'm going to do a lot less of the detail. Okay, so we're not, you already now have a good technical and a good background in what we're going to try to do. In a nutshell, I look at the Affordable Care Act as being about better access to health care. The theory here is that if everyone has access to health insurance, it will make it possible to get health care, and when you get health care, it will keep you healthier. These are, I think, I have taken a lot of very complicated and detailed things that Steve talked about. I've turned it into like 6 bullet points that I think are kind of the key to health access, just to the healthcare part. Free prevention benefits. Some of these are already in the law, and they have been since the past 3 years ago. Some of them are just now coming up. Free prevention benefits. A lot of people already have gotten mammograms and free flu shots and the kinds of things that keep us healthy. No more lifetime limits on care and coverage cancellations. This would drive people crazy. When they got sick, that's when their health insurance ran out. You know, so sometimes it just ended right in the middle, right at the end of the year. No more of that. We've talked already about the coverage for young adults to age 26 on their parents' dependent health plan. More affordable prescription drugs under Medicare. That's what Steve talked about is the donut hole. Now the federal government with the Affordable Care Act is beginning to close that donut hole, so some years from now there won't even be a donut hole if you're on Medicare. This next one, probably the most important of all, that you will have coverage, people will have coverage even if they have pre-existing conditions. So I love to tell my health insurance company colleagues and people I work with that for all the years that we've had health insurance in the United States, they really liked covering healthy people. But those that had these conditions, nah. So pre-existing conditions, you know, were among those things that they wouldn't cover. And I have to tell you, the time that I was a state legislator, the most troubling group of people who would call me were pre-Medicare, so they were middle-aged people in their 50s and early 60s. And by definition, we all have pre-existing conditions when we get to be middle age. And if they happen to be between a job or they lost a job or they were self-employed, they just couldn't get health insurance because of a condition. Going away. It's already gone for children. January 1st, 2014, no matter what your condition, you will be able to get health insurance. That's a really big reform in the United States of America. So this is about universal coverage. Steve mentioned, what, 50 million people currently uninsured? Last numbers, 50 million people. But after January 1st, 2014, everyone will have access to, and I didn't even mention Medicare. Medicare, some of you already know, because you're on it, for seniors over 65. But everyone will have access to, through employer insurance. Those are what we call group policies. So if you're part of a group, it doesn't have to be an employer. It can also be, I think, a university, a college sometimes offers group policies. You can have access through group policies. You can now buy individual insurance. I'm going to talk about that. Or if you're low income, you will have access through Medicaid. So to bring down that big number, 50 million, right here to Illinois, we believe there are about 1.1 million or 1.2 million uninsured right here, right now. Half of them will qualify to buy health insurance on this thing called the health insurance marketplace. We're going to talk about that in just a minute. So 500,000 or so will go out and buy health insurance. The other half are low income, and they will qualify for Medicaid based on their income. So what Illinois has to decide right now is whether we're going to run our own health insurance marketplace and whether we're going to take that United States Supreme Court option to cover people on Medicaid. So yes, it turns out the Illinois legislature did not pass a law to have us run our own exchange, but we are going to have one. And it's not going to be called that anymore. It used to be called the Health Insurance Exchange. Now it's called the Illinois Health Insurance Marketplace. You don't have to remember either of those words because by this summer there will be a better name. What we are expecting is that there will be a big outreach effort, and their first job is going to be to give it an easy brand name that people will remember. But it won't be run by Illinois because, like I said, we didn't pass it. Exactly. So the federal government is going to run it. It probably doesn't make that much difference, but we are going to have one, and it will begin on October 1st of this year, just a few months from now. People will be able to start enrolling, and their coverage will begin January 1st. I think that's the same as the Medicare enrollment period, about that same fall period for 3 months. And if the legislature doesn't enact a law, the federal government will still run it. Now, what is this thing called a marketplace? I think of it as a website. A website, with a brand name. So if any of you have ever gone on to look for travel plans, if you want to get travel, you want to look up American Airlines and where they fly and how much, where do they go, when do they go, and how much you have to pay, that's what this is going to be like. It will be a place where people can shop for health insurance. And just like if you go on Expedia or Travelocity, it will let you compare. It will let you compare health insurance, not travel insurance, health insurance policies. And the goal of this is one-stop shopping, easy to use, turning it into consumer-friendly language so nobody should have to read a big book like that, which is a health insurance policy, in little teeny tiny print. You'll be able to go on this website and compare apples to apples and figure out what kind of health insurance you want to buy, you as an individual. And then you can see typically what people will decide between these policies is, let's see, where's my doctor? Where's my hospital that I want to go to? So which policies offer which plans? That's often how we make those decisions. I think that's also true for Medicare in some ways, right? You will also be able to say, well, if I pay a little more for my deductible, and if I pay a little more for my copay, then maybe I can bring down the cost of the premium. So again, it will show you side by side what you would have to pay, what kind of, which one you might want to pick among, and it will be all in easy to use, they tell us, they've promised us, easy to use consumer language. Now, the really important thing that we haven't said yet is that sometimes health insurance is expensive. But what the structure of the Affordable Care Act is, again, low-income people, Medicaid. If you're slightly above that income level, all the way to that's called 133% of federal poverty level, all the way to 400% of federal poverty level, you're going to get a tax subsidy to help you buy the health insurance. So with that range, the 400% is about $80,000 for a family of 4. So you probably know some people who don't have insurance today, but they're making they're making $80,000 or less. They'll be able to buy insurance if they don't have access to it, if they don't have a job or they don't have insurance on the job. They'll be able to go on this website, pick and choose between health insurance plans, put in their data about how much they make also. That will search the IRS records for that person and will verify that that's how much they reported to the IRS. And then they'll be told how much of a tax subsidy they'll get to help them pay for the health insurance premium. That is going to be a pretty easy system, they tell us. So we haven't seen this yet, but that's going to be the concept. Go ahead.
Okay, so all these insurance companies...
Wait.
You don't want
I'm sorry.
You don't want any questions? Hold your questions, please.
The reason we can't have questions is you won't be televised.
Ah.
So the audience watching has no idea what you just
But we'll
asked.
come back to it.
So I need to go around with the mic when we do that part. I'm sorry.
Okay.
So, thanks.
So that's going to be the concept. That's what the exchange is, and that's how people will have access to health insurance through this exchange. And by this summer, late summer, early fall, but certainly before October 1, we will all see a big marketing effort. You know, when they did this in Massachusetts, they were showing it at the Red Sox games. Buy insurance, it's the law, right? So there will be a big marketing to remind people that it is the law, that they have to have health insurance, and to show them where they can go to get help, to buy their health insurance. This I'm not going to talk about too much except to tell you that these are comprehensive health insurance policies. If you take a look at this, there are 10 different items that have to be covered by every plan that's sold in the marketplace. Every plan will have maternity and newborn care. Every plan will offer prescription drugs. Every plan will, of course, include the lab services, the hospital services, preventative and wellness, pediatric services. So these will all be comprehensive. So the differences between them are not going to be about how comprehensive they are. The differences between them will be kind of what I said. How much you want to pay for deductible, how much you want to pay for copay, and that's the way people will be able to decide that. And the way you'll do that is that the plans will be they'll be given a name. There'll be the bronze plan, the silver plan, the gold plan, and the platinum plan. And if you want a platinum plan, the top of the line plan, you'll probably be paying a little more than for the bronze, but that's a decision that people will be able to make. It's your choice, and you will be able to review exactly what that means. So they're called metal levels, and these are the 4 metal levels. But again, the exchange or the marketplace is going to walk you through all of that, and is going to compare. So again, apples to apples comparisons. The only exception to what I just said, they finally put in something for catastrophic coverage for young people. So I guess there was a theory that, and maybe you know more about the background for that, that young people under 30 may not need maternity and newborn care, for example. That what they really need maybe is catastrophic care, so God forbid they should have to go to hospital, they'll still have some kind of coverage. So there was an exception made for young people who have a very specific kind of policy that's available to them. And again, there are rules about that we don't need to cover. And Steve already told you about the fact that this is called the individual mandate. Individuals are required to have coverage. So everybody has to have health insurance, a little bit like our auto insurance. You know, we don't think about driving a car without buying auto insurance. That's what this is going to be like. Everybody has to have health insurance. And there are, again, some different rules, but you will have tax subsidies all the way up to $80,000 for a family of 4. You will have some subsidies to help pay for it. And there is this tax penalty. Now, the only thing I didn't like about what Steve said is when he was talking about the tax penalty. Yes, it does look like the tax penalty is kind of modest. And some people may decide, is it more expensive to buy health insurance or not to buy health insurance and just pay the penalty? And that's true. What I didn't like about the way he presented it is that for many years now, especially as a public official, I have heard from people who want to buy health insurance. They understand that coverage is so important, that if you're going sort of bare bones without it, it's really scary, and that a huge number of bankruptcies result in that, and you will be hit with the most significant fees that hospitals even charge. So I'd like to think that when people see $2,000, let's say for a family, deducted from their tax refund, and they'll say, I didn't get anything for that, what's the point? Then maybe they'll say, you know what, our family really needs health coverage, and we'd rather pay, maybe even pay a little more, than pay a penalty of $2,000 and get nothing for it. So I think that the new norm is going to be in the United States of America that people will want and will have access to health care. That's certainly what I am guessing. We don't know yet, and it might not be true in the first year. And as we said, employers over 50 are required to offer it. So again, it's a fair share concept. Government helps pay, individuals help pay, employers help pay. That's really the fair share approach. Now, I want to talk to you about just one other component we haven't even talked about yet today. And that has to do with Medicaid. So let's start with the basics. Medicaid is not Medicare. Medicare, that some of you already have access to, typically over 65, although also some people under 65 who are disabled have Medicare, but over 65. Medicaid was designed as a program for low-income people. They both came about at the same time, 1965. And by the way, when Medicare was designed and was created, and Steve showed you the numbers at 94% supported or something, in its day, it was just as unpopular as Obamacare. People saw it as socialized medicine. And now look at how it's gained in popularity because people realize that we don't want our seniors to go bankrupt in needing and getting health care. Medicaid, the same thing. Medicaid is for low-income people, and we have in Illinois Medicaid 2.7 million people enrolled in Medicaid. Now, it is for very low-income people, but it's not the only thing that you need to qualify. You also have to fit into a category. So it's low-income plus a category. And here are the 4 categories. Children under 19, in Illinois we call that the All Kids program. People with disabilities who meet the Social Security, which means they're permanently disabled, they qualify for Medicaid. Seniors, now seniors, as we said, get Medicare, but if they're low-income seniors, they also qualify for Medicaid, and often we will help pay nursing home bills for people who are on Medicaid. Medicare doesn't cover nursing home care, but Medicaid does. So seniors can be both, Medicare and Medicaid. And the 4th one are the parents of the children, parents and caregivers of those children. So who does that leave out? And who has been left out since 1965? The new group has been forever left out. They're adults, 19 to 64, and they don't have children. Often, these are men, or the group I described to you, the middle-aged couple or the middle-aged person who doesn't have a child at home anymore, they're empty nesters. They haven't qualified for Medicaid, again, if they're low income or between a job or haven't been able to get health insurance because they're self-employed and they're not making enough. They haven't qualified, but now they will. So it's low income, and look at, and I thought I had, yes, the income. 133% federal poverty level is only about $15,000 for one person. And often these will be single people without children. Very low income, 15,000, they will qualify for Medicaid. And the federal government has said, we're going to pay you, the state, 100% of their costs of providing that care for the first 3 years. And even after that, it goes down to 90% over time. Now, in regular Medicaid, we pay for Medicaid 50-50. The feds give us 50, we pay 50. For the newly eligible Medicaid, 100% down to 90%. It's the most generous federal match ever given because they understand that when these people remain uninsured, it shifts the cost to everybody else in society. So it's worth it to pay for that group and get them access to health care, keep them healthier. That, I think, is the theory, and it's a good one. So for Illinois, we expect the other half of that 1.1 million, 509,000, will qualify. 2/3 of them are this brand new group, the newly eligible adults, no children. The other third are people who are already qualified today, but they've never signed up. And maybe if there's a big marketing push, they will sign up too, so we have to be prepared for it. So these are quickly the challenges for us on the Medicaid side. First of all, we need the state government to approve this. So remember, the United States Supreme Court said it's optional for the states. If it's optional, we need a state law, and that's right now before the General Assembly. The second one, the one that keeps me awake at night, we need healthcare providers willing to serve 509,000 more Medicaid clients. And let's add to that the other 500,000 who are currently uninsured. So we need providers who are willing to serve and able to serve 1 million more people in this state. That's a really big challenge. The federal government is putting some money out there right now for primary care physicians to attract more. We always pay our bills on time to those physicians, even though we don't pay our bills on time for anybody else. So that's good, but still it's very challenging. There are not enough doctors in the pipeline to serve all those people. There just aren't. Correct, Steve? So it's time to think about the other alternative healthcare professionals who we need to serve people according to their scope of practice, what they can do. So when you go into a Walmart or a Walgreens and you go there for some of the services that are provided there, those are advanced practice nurses. They don't have a doctor on site, but the nurse knows what she can do, he can do, and that's what they do. So we need to rethink what some people can do and to bring those of them into the fold much more quickly. Thirdly, we are redesigning Medicaid. I think our Medicaid system is broken. I got there 3 years ago. I was the legislator for 11 years. I still didn't know that it was going to be pretty messy, and we had to do a lot of changes. We're trying to make those changes. And the newly eligible have to get into that whole new mix of services. This is a really important challenge. So think about this. This is this issue. 1 year a person is on Medicaid. They're working, as Steve said, people who have who work full-time sometimes don't have insurance. Sometimes those people are minimum wage people. They don't have insurance. Now they would qualify for Medicaid maybe if they're working a minimum wage job. The next year, they get a little bump in their pay. They get a few more hours. They no longer qualify for Medicaid. Now they're shopping for health insurance on the open marketplace. Third year, back to Medicaid. We have to really make sure if we want people to be healthy, we have to have that continuity of care so that people don't have to start with a whole new doctor, a whole new set of records, duplicate procedures, more tests. So this issue, they call it churn. It's not a very elegant name, but it's back and forth. People, we need to think about how we're going to manage that. And fifth and last, we are overhauling our whole system, because here's what's going to happen. When you go on that website, it's going to direct you, if you're over 133%, you go one direction, right on the website. If you're under and you qualify for Medicaid, it comes into a whole new modern system that we're building. We have a brand name. We're calling it ABE. Application for Benefits Eligibility. And that ABE will in fact determine if you're eligible for Medicaid and even if you're eligible for food stamps. So it'll be our internal modern system of verifying eligibility. So these are big challenges. It's an exciting time. I've also given you some references for where to find out more. You'll be hearing about lots of stuff, because I think in the next 3 months, it's going to be the news. Every time you turn it on, we'll all know more about what to do. Thank you.
Thank you, Julie. Okay.
So do you understand it more? A little more? Okay, good. Let's shake hands. Good. That's our goal.
Understanding. I've got the mic now, and I'm going to walk around and take questions from the floor, because this is the only way we can get them televised. So if anybody has some questions, let me know. There was a lady back here. I want to be sure your question, you got your question answered by the next slide. Okay, that's great. Ooh, yes, sir.
Yes, this question is for Steve, who presented some, for me, startling facts prior to getting into the meat of his presentation. And one of the that he cited was called healthy life expectancy. And I guess my question would be, is there such a thing as unhealthy life expectancy? What is the definition of healthy life expectancy? Is that any different from the average age at which all people die?
Well, you know, in healthcare, you're not trying to prevent ultimate death, right? We're all going to die. And if I talk to this audience in 50 years, of course I won't be here in 50 years, but if I did in 50 years, you'd probably all be dying from the same causes that people are dying from today. But the point is, you want to compress the time you're ill. So you're compressing morbidity, illness. So when researchers look at that, they look at how well people are living until they die. Okay? So for example, if you are 3 times at risk of late-stage breast cancer because you don't have health insurance, then your period of illness can be substantial before you die. So all of us in this room want to be able to walk to our grandchildren without oxygen, right? We want to be able to climb a couple flights of stairs without getting very short of breath. We want to garden for an hour or so without being able to just sit down and be exhausted. So part of that whole scenario is, how many years do we have of healthy life before we all die from the same causes? I do want to mention one other a quick thing. Julie mentioned that when Medicare came out in the 60s, there was the same amount of concern and opposition to its passage as we had with the Affordable Care Act. And there's a famous individual, he was not in politics yet, but actually made a radio ad saying, if Medicare is passed, Americans will lose their freedom. Does that sound familiar? Americans will lose their freedom. Yeah. Who was that?
Ronald Reagan.
Ronald Reagan.
Exactly.
And who paid for that ad? The American Medical Association.
That is a really great factoid.
Okay, more questions. Yes, ma'am.
I have a question. If the penalty for not going into the exchange is $95 a year, and the appeal is to get young, healthy people into the exchanges because then you have good claim experience. Stop young, healthy people from paying the penalty, which I understand the government's not going to go after them for until something comes up with the IRS. But what's to stop a healthy person from not getting insurance, taking the risk of having to pay the penalty at some point until they need the insurance? Since pre-existing conditions are covered day one, why wouldn't they just wait until they're sick?
Julie, you want to take
Right.
this
Well,
down?
I actually do think that the penalty's too low. It could have been a little higher to get people to fairly balance what one side versus the other. The $95 in the early years gets to be a little larger, but still pretty small. It's still cheaper than buying insurance. It will be, in fact, deducted from your next tax refund. Just they're not going to let you slip by and collect it later, but it will be deducted. But still, it's still going to be a problem. And it's going to be a problem if a lot of young, healthy people opt out that way, because what it really does is it skews the entire pool. Okay, so the one thing that we really didn't talk about is that the reason it's been impossible for individuals to buy individual health insurance, or even in small businesses, why health insurance goes up and up and up, is because the pool is so small. And when insurance companies come in is they look at the risks within that pool. And if you're buying individual, no hope. And if it's a little larger and one person gets cancer and another person gets pregnant, no hope, that health insurance is going up. The theory of this health insurance marketplace is that now we have a pool of 500,000 different policies, so it's not all 500,000, but you will be part of a larger pool, and therefore the risks will be spread out across a much larger group of people, and that will bring health insurance costs down. Now, if the larger group are all sick because the healthy people stayed out, that will in fact skew it, and I think that will make it more expensive for everybody else. And I believe at that point, I think they would come back in and revisit the whole issue of the penalties.
And then
I think.
That 1-to-3 ratio on the premiums?
The question is, does it impact the 1-to-3 ratio on the premiums?
And what do you mean by that?
Because you're going to have bad claim experience, so
Yeah.
you're going to have to raise
Oh.
premiums.
That's the worry, is that they will be raising premiums. I mean, the whole goal of using private health insurance here and trusting that they're going to do the right thing and we're not going to have just hugely expensive premiums is, number one, this large pool. And number two is that this is the largest expansion of a health insurance market in a long time, if ever, and they will be competing for our business. So they will be offering policies within the limits. You know, those 10 essential health benefits will still be offered, but there will be some doodads and some incentives to pick a plan over another plan. And when they compete for our business, then the health insurance premiums hopefully will in fact come down. That did happen in Massachusetts. That did. Not the first year, but after it played out a few years into it, in fact, that stabilized as a very healthy health insurance market, and it's popular. 98% of the people have bought health insurance. They could have opted out there too, but they didn't, because people know that it's access to health care, and they have now figured out how to make it low enough so that people are interested in buying it. But we don't know yet.
Steve?
It's a real concern.
If I could just make a comment on that. We do say about 95 per adult and with 47 additional for children. But there's another caveat, and that's a % of your income.
Yeah.
And so remember, it might be substantially more than $95, depending on what your income is. So there are those percentages that try to suggest that maybe there is a little bit better cost-benefit analysis the person might make. The other thing that I want to mention too is that one of the things here that is trying to be corrected, for those of you or have family members who have tried to get insurance in the private marketplace, you know how difficult it is sometimes to compare plans? Very, very difficult. In fact, you know, I have working children, adult children, and their company almost every year changes the plan. So one year, they think they know what their benefits are, and the next year, those benefits are different. So the beauty of this system is that there will be 4 plans, again, based on coinsurance and deductibles and that, but they will all have essentially the same fundamental benefit package. That's very important, because if you're going to compare, you need to compare apples and apples. You have to know what the plan gives you for its cost. That is a tremendous advantage to this United States, to actually be able to say, I know what the plan covers. I don't have to read 5 pages of small print. The other thing I want to mention is an historical fact. When Medicare first came into existence, there were all kinds of different plans. And the seniors were going nuts because they couldn't compare plans just like you can't compare plans really well in the private marketplace today. So what did Congress do? Congress mandated an A and a B and a C and an F, right? So when you compare your Medicare supplemental plans, if you want an A, every company that offers an A has to have the A benefits. And there's a chart. You can see exactly what those benefits are. That's exactly what's going to be transitioned into this process. So you will compare exactly the same benefits by each insurance company and decide what insurance company you want to use in the marketplace. A tremendous advantage.
when we have this website that we're able to compare on, when I was looking for supplemental insurance for Medicare, and I know the ABCDF, all of that all made it clear, but if you wanted to get information from 3 or 4 companies, you almost couldn't find it as a comparison on the website. You had to give them some information and they called you or they emailed you. Will this truly be where you can have 4 companies up there without contacting the companies previous to getting the information from them?
Yes, because this will be actually a government-sponsored website. So the plans will have to be qualified health plans. The only, I mean, it's interesting, you know, some people have blamed Obamacare for too much intrusion by government. The only thing government's doing is offering a website. And the website and the plans that are on that website will have to be certified by our Department of Insurance. So it's a one-stop shopping place. What you have to look at now, I'm guessing, is the individual companies sponsor their own websites. This is the official website for Illinois. That's what you will be looking at to see what's being offered in Illinois.
If I could, someone handed me a question, so I'll get to you in a second, but let me ask the question. If someone over 75 needs surgery or whatever, does a panel decide what they'll get? Does a panel referring to Obamacare decide what kind of services they're going to get?
We don't believe so, and we hope not. Because again, there's only 2 components of that, and that's the Institute of Medicine and U.S. Public Health Service. And they don't decide on individual care. What they decide is what is cost-effective and evidence-based for care. They don't decide on individual people. Now, from a physician's point of view, let me just say that a lot of health care is unnecessary. And we have studies from Harvard, and the internist group are saying that. So hopefully, when the system gets more transitions from volume to value, physicians and hospitals will be making better decisions on whether or not that care is necessary, but necessary based upon evidence. We already have, you know, a malpractice situation. We have checks and balances. So if you need care, it's hard for me to believe in the United States today, of course, unless you don't have insurance, that you won't get that care. So deciding in that is a personal decision between you and your physician, but hopefully it will be based upon the evidence that you need that care. We saw in the articles recently and in the news how one of the local hospitals in Chicago was doing trachs and doing many unnecessary procedures, right? Well, you know, that never should happen. You know, it should never happen. So hopefully, if you need the care, there's nothing in the act that will say you can't get it. But hopefully, it'll be necessary care.
That was disgusting. That's one of our hospitals too, and they do a lot of Medicaid work too. That's fraud. Now we're not talking fraud. We're talking about overutilization, right? So let me tell you a story of something that's in my lap right now. This is a 67-year-old woman somewhere in Illinois who has found her way through her doctor has referred her to a surgery practice in Indiana, but she's Illinois Medicaid, to Indiana because it's the only place close by that does this particular procedure. So think of it this way. We have all these state-of-the-art hospitals in Illinois. Not a single one wanted to do this. She had to go to Indiana. And what it is, it's multiple transplants. So it's basically replacing like 3 organs. Exactly. That's what I said. So can you imagine how much this costs? We're guessing $2 million before it's over, right? Now, one of the questions I asked first is, she's on Medicare. She's 67 years old. What happened? And they didn't tell us about Medicare. They hoped somehow we weren't going to figure out that 67, you're over 65. But we did. So now we went back to them and said, what happened with Medicare? And you know what they told us? They knew that Medicare wouldn't cover this. They knew that her supplemental insurance wouldn't cover this. So they came to Medicaid thinking that we would have more lax rules. These are life and death decisions, though, so I don't want to pretend this is going to be an easy one for us to make. But Medicare does, in fact, in some cases, decide. Now, I think they didn't, I'm not even sure they went to Medicare, because one of the things that we found out is that even the surgery practice has written about this. I mean, they do a lot of research and they publish their research, so we read everything they've ever written about this, since nobody in Illinois even does this. And one of the things they said was that for people who have liver cirrhosis of the liver or liver cancer, this is not even recommended. This client has cirrhosis of the liver and liver cancer, both. Why do they do that? Exactly. So it sort of gives you a little glimpse at how tough the decisions are, but how sometimes just to get a procedure under their belt so they could chalk it up to part of their practice, or for that facility to get a very high fee that we would be paying for in a very significant ways. I mean, who knows why they make those decisions. But here was a doctor recommending it. Medicare says no. Now it's in my lap. And it's a very challenging one, just as one example of a life in the day of the Illinois Medicaid program.
Yes, ma'am.
I'm just really trying to understand all of this. I've called Blue Cross so many times in the last year trying to understand what happened in 2013 versus what's happening in 2014. So it's my understanding, my takeaway today is that the marketplace exchange, whatever we're calling it, is only for the uninsured, and you have to be between 133% to 400% of the poverty level in terms of your income to be able to tap into the exchange.
To get a subsidy.
So you can still, because I'll tell you where we're coming from as a family. We are self-employed, we are self-insured.
Yeah.
And in order to keep our rates within our budget every year, we've had to go to higher and higher deductibles and now have more of a catastrophic plan. So now as my husband and I have started to age, we have been trying to upgrade through Blue Cross when we're self-insured. We have an individual plan. And I was told to reapply in 2013. My rates should come down and I should be able to, for the same price, I should be able to get greater coverage, lower deductible, and just a better policy. And so I went through that whole process and then was denied to a pre-existing condition. Okay, and so I was just couldn't believe that I was denied by Blue Cross. We have had them for years. So they told me, oh, things will get better in 2014 because you can no longer be denied. Our physicians don't even understand what the affordable health care means. They just don't even have a clue, because we'll go in for basic procedures and they keep saying, well, that should be covered. It's 2013. Those should be included now with the change with the Affordable Health Care Act. So they don't even understand how it's impacting their practice. So I've tried to share with them everything I've learned. I document every conversation with Blue Cross this year, really trying to understand. So I was denied. Our family then,
wow.
Family of 6 was denied. So is there any relief for the self-insured, where maybe we're not so economically deprived that we qualify for the exchange with a subsidy, but I'm very open-minded at this point to, tapping into possibly an exchange. For our family, it would be better if everybody in the world were on this exchange, because everybody would be in a free market, struggling, trying to make it more competitive so we all pay, less expensive rates. But most people in this community, anyhow, are on group plans, and most of the physicians in this community are used to dealing with people who are covered by their employers, have group policies with low deductibles, and they have tremendous coverage. Those people never have to pre-qualify, or they don't have to find out what the actual cost would be before they go to a doctor. With our family, again, we're on a tight budget, so I always find out the actual contracted rate before we go in for any test, any procedure, because all we have in our policy right now is one annual wellness visit, which doesn't cover much. So, you know, at first our doctors were shocked because I'd call and say, okay, what's the diagnosis code? They don't know, they haven't even seen me yet, but give me a guess, you know, diagnosis code, what's the CPT code, is it inpatient, outpatient, in office, you know, and you have to get all this information to submit to your insurance provider before they can tell you what the contract rate is between your policy and your provider for that particular service. It's laborious. And then after you get all that information, you get the exact diagnosis code, CPT code, then they tell you it's just an estimate, even though you're giving them exact information. And it is just, I just don't know how to make it easier. So I keep thinking, what's happening in 2014 that's going to make life easier for people who are self-insured, that maybe aren't in the poverty level? I'm curious, is there anything positive to look forward to?
Absolutely, and I'm so sorry. I mean, this is a great question because I'm going to go right back and rewrite a slide to make sure it says this. This is not, the marketplace is not just for the uninsured. It's for people who want to buy individual coverage. So remember, I started on page 1 by saying this is about universal coverage. You can get it through group, most often through your employer. You can get it individual, now through the marketplace, or if you're low income, Medicaid. So the people who are shopping for individual insurance because they're self-employed or uninsured or unemployed, or, I mean, we don't know yet how it's going to play out with people who are employed and the employer drops coverage. We don't know about that group yet. But there is going to be a marketplace for you. You do not have to say that you do not have to show that you're uninsured or we're uninsured. You'll be able to shop for health insurance like anybody else. If you happen to be between those two income levels, then you also get a tax subsidy to help you pay. If you're over that 400% federal poverty level, then you're going to be looking at market rates, but again, as part of a bigger group than you've ever been before, 6 people, and hopefully they'll be competing for your business and the rates will come down. And Blue Cross, I'm pretty sure now, in the next 2 weeks, by the end of April, we're going to find out which health insurance plans want to sell on the exchange. We don't know that today, but we'll know that by the end of the month. That's the day. I'm guessing that Blue Cross will be selling on the exchange. Not sure, on the marketplace.
Currently, right now, in 2013, you had to be uninsured for 6 months in order to be able to
That's a different plan entirely,
okay,
going
so
away.
That goes away in 2014.
Okay. That's correct. And it is true that some things did kick in. I mean, Steve has very lengthy slides about what kicked in 2011, what went in 2012 and 13. What you went to your doctor for may have been in part preventative benefits, and those preventative care has been free, even under the Affordable Care Act. That was one of those things that did kick in early. I got a free mammogram during this period. So some things, it became a little complicated because some things were not yet, some things were. By 6 months from now, or 8 months from now, it's going to be much simpler because everything will have taken effect.
Steve?
Just a couple comments. First of all, we can't stress that enough. This is not just for people under a certain income level. It's for everybody who wants to see if the exchange is better for them. The second thing is that the law says you can't deny care or insurance based on pre-existing conditions. So in your situation, that would eliminate the denial issue. And the other thing is that the law specifically says you cannot be biased against women. Women in this country traditionally have paid 18% more for insurance coverage than men. That will no longer exist with the law. There has to be parity. Whether you're male, female, you're going to pay the same price for your insurance coverage.
Okay, hold on.
Pardon me, we started this very interesting discussion with the point being that our costs were higher than anywhere else in the world. Is anything in Obamacare addressing costs and the lack of transparency from policy to policy?
That's really a complicated question.
Yeah.
Yeah.
No law is perfect, and Obamacare is not perfect. And one of the areas it's not quite perfect in is because of cost issues. Now, I say that with also the caveat that there's a great progression of health policy and cost issues in the law. It's just not caring for everything. And for example, Medicare by law can only have 10% of its premiums for administrative costs. Right? The insurance companies have typically done around 20 to 30% of profit versus the premiums. The law says it now has to go down to either 85% or 80%, depending upon your large employer. So in that regard, the law is saying hopefully the premiums will be adjusted because it will no longer be 20 to 30% profit. It can only be limited up to about 15%. And I don't know if you know this, but there has been a number of $1 billion rebates already because insurance companies have spent more over the past couple
But
years.
let me give you another answer too, because I think
It wasn't just the cost of premiums, it was the cost
of the health care, that's right. And that's why it's such a complicated question, and with no easy answer. And what I'm about to say is just the tip of the iceberg. But it is true that in Illinois, as well as all over the country, there is a national reform effort to really look at the way we pay for health care. And in Illinois, we just launched this. We're in the planning stage, and here's the concept. We're bringing all of the payers around the table and the major providers. So we're a payer, Medicaid's a payer, Medicare is a payer, and private insurance is a payer. We all need to be at the same table, we're at the same table. And the really complicated concept that we're working on is how we can pay together, how we can pay to keep people healthy instead of only paying them when they get sick and then charging us for every procedure with quantity, not quality or value. This is a national movement, and everybody can tell you what I just said, but that's about all we know. So it's the concept of really redefining payments, but we don't know yet how we're going to get there. It is in some ways the only hope of changing this stuff. Because if we keep, I mean, it's so true in Medicaid. Right now there are people we have 2.7 million people in Medicaid. They get procedures. We won't know about those procedures for 6 months because they have up to 6 months to send us their bills. And the more procedures they provide, the more we pay. It's exactly the wrong incentive. So the incentive has to be turned on its head so that the fewer procedures but they're meaningful and they keep people healthy, that's the new way of thinking about this. We don't know yet how to get there. But I believe that the national administration created something called the Center for Medicare and Medicaid Innovation, and they're really pushing the states and the local providers to think very differently, to think very much outside the box, and I hope we'll get there. It's very challenging.
Okay, I see a couple more questions. Hold on.
Could you tell me how this is going to impact new procedures or experimental medicine? Because it seems that only tried and true procedures will be paid for, and that there would be some long period of determination that have to be made about experimental procedures before they would be mainstream enough to be paid for. So what would be the Affordable Care Act's impact on research and new procedures?
Most of the research in the United States, the big research institutes, are sponsored by the NIH, National Institutes of Health. And that's multi-million dollars every year that go for that research. That research is then, obviously it's called research, so it's published, right? And the publications then come out. Now, will there be a delay in evidence-based care? It's not so much evidence-based care. These groups that I showed you are based on screening procedures or population-based services like mammograms for women, stuff like that. They don't tend to be based on individual kind of operations or that. If there's a quality institution that shows that it's beneficial for the patient, those are not denied. I have to go back to the cost issue just for a moment. I mentioned the insurance issues, but Julie's right. There's a whole issue about care. And remember I said there's techniques called bundling, and there's techniques where they're going to pay for a certain chronic condition to be cared for, not based upon all the tests you do or the CT scans that you don't need, but based upon making that patient is as healthy as they can be. And so providers, if they participate in these systems, and most of them will be voluntarily, that they will get a sum of money to take care of that patient. So there will be financial incentives not to spend a lot of dollars on unnecessary stuff, but only the things that are going to help the patient. Because there's a couple other provisions, just quickly. In Medicare, for example, if you're hospitalized, there are disincentives for hospitals in the Act that if you're rehospitalized in 30 days, you get penalized, okay? And there's for like 4 or 5 conditions. And the reason is, in those 4 or 5 conditions, if you have good outpatient follow-up, you should not be hospitalized in 30 days, okay? So that's part of the new process. And there's a lot of conditions that people are readmitted in 30 days. So hopefully that will be a financial incentive to take care of the patient, to link them up good outpatient services so they don't come back in. However, there's a lot of different issues. For example, if you're on Medicare today and you get hospitalized, you know that you can be hospitalized in an observation bed? Now, you'll usually get a form to fill out to say, okay, I can do that. But the observation bed is not a hospitalization. So you could come,
I know worse procedures than that.
So you could come back in 30 days and the hospital's not done. The other thing that I think is very important, and I want to mention to this group, because it tends to be a group that tends to have a lot of Medicare, it looks like in the audience. I do too, by the way. If you're in an observation bed and you're discharged and need rehab, Medicare will not pay rehab. You have to be hospitalized for 3 days. So if you're going into the hospital with a condition that you think you might need PT or some other rehab services, you need to make sure you're an inpatient and not an observation patient.
Julie, you want to say anything to that?
No, that's okay.
Okay, wait.
There's many more just like that. That's okay.
Wait. We can't pick up your question, ma'am. So she asked if whether or not that decries the model that you're trying to establish here.
If that tries to...
Decries the model.
Because you're hospitalizing somebody for 3 days.
In other words, how does one stay out of that?
Right, the incentives kind of are distorted.
Every system has mechanisms to game the process.
Yeah.
Every system, right? Banks, mortgages, whatever. I'm not going to get into whether or not that's good or bad. All I do know is for some patients that might need rehab care, getting into an observation bed is not good.
Yeah.
So, you know, I happen to have a hospitalization myself personally about a month or 2 back. I was in observation bed. I could have potentially needed rehab, but I didn't think I did, so I didn't appeal it. So, I mean...
But you're the only one that would even know about that. Yes. Most people wouldn't know one way or the other until they got to the point of discharge, and all of a sudden, whoops, that didn't help.
But there are cost savings. If you're in an observation bed, sometimes that cost is less than if you're in an inpatient bed. So there are some trade-offs.
Right.
Okay, we have a couple more questions and then we need to end. Sir?
What will happen to the Illinois Comprehensive Health Insurance Program, the iChip program, the first
I think it's going to phase out. I mean, part of it is, so this has been our program in Illinois for people with catastrophic conditions who did not have access to health insurance because of pre-existing condition. It doesn't help them, it doesn't help us as a state to keep that going, because then people won't be able to benefit from tax subsidies if they're in that income range, 133 to 400%. So we want to help people qualify for health insurance, no more pre-existing condition problem, and also get the tax subsidy that the marketplace will offer. So CHIP is an incomplete kind of system in the new world.
Wait.
The decision has not been made how it will phase down or phase out, and in every way possible, there will be a lot of work done with all the people who are getting benefits through the CHIP program to make sure that they're transitioned in the appropriate way.
Okay,
But it's not a final decision, but my sense is that's the direction it's heading.
Did you have a short question?
Well, I did, but first I wanted to ask, but it was answered, about this, if it covers Medicare patients. And it does, now I realize it. But I have run across something where things I used to be reimbursed or they would pay the doctor for, they're now not paying the doctor for. And it's necessary for the problem I have to be diagnosed constantly to see what the progress of the disease is.
Okay, so let's see what they say.
I don't know of anything where doctor payments have been reduced for Medicare. I do know, and we all know, that some doctors have opted not to take Medicare patients anymore, and that's very unfortunate that they've made that decision.
There are two of them, and they take me as a Medicare patient.
But in a limited way, with some limits.
Yes, if I want this, the tests are necessary.
Yes.
So I end up paying for them.
So,
because Medicare used to pay for them.
I don't know.
But as of January 1st, they're not.
Yeah, there's an appeal process, and we would encourage you to do it, because I don't know if it's Medicare that decided not to pay, or the doctors just decided to bill you. Not sure. It's just hard to know that as a general lie, because again, doctors are getting out of Medicare, and it's really too bad, but they are, and sometimes they're selling sort of this boutique service, right, where you're paying for everything out of cost, out of pocket. You should appeal it. That would be great.
Steve?
Because we don't know what it is.
Sometimes physicians are paid for a certain procedure and then required to do certain follow-up as far as that payment. So I don't know your specific circumstance, but say, for example, if you happen to have a surgical procedure, some follow-up visits, physician can't bill extra for that because Medicare will not pay extra. That's part of the package of that service. In addition, sometimes Medicare does say that in general, 3 or 4 additional things involved with that particular diagnosis is not standard. But in individual cases, sometimes it needs to be standard. And so there is an appeal process, and I would certainly suggest you try to appeal it.
Okay. I'm sorry, but this is the end of our evening. I mean, I think we could probably stay here for a long time asking questions and listening from these two speakers we've been privileged to hear from tonight. Some more words of wisdom, but the evening needs to come to a close. So I want to thank you, the audience, for participating, for coming, our viewing audience, for watching. And I certainly want to thank Julie Hamus and Stephen Patzek for being here this evening. And just stay healthy, everybody, as long as you can.
Thank you.
And get home safely, okay? Good night.